Good afternoon and welcome to the ILF 2023, live from Nottingham, and this afternoon's Industry Live session. I'm well aware how busy you guys are, so to join us and to give us your precious time means a great deal to me, our speaker and the team here, so thank you so much. The session today is called Big Legs, Always Lipedema Syndrome, Practical Aspects of Differential Diagnosis, and our fantastic speakers with me now, Dr Tobias Bertsch, welcome.
Welcome.
Thank you for coming. Are you enjoying the event?
Wonderful event. Perfect organized, great lectures. I enjoyed very much.
Fantastic. Well, thank you for coming and thank you for this session. As you can see, we are live, so if we have any technology breakdowns, please bear with us and I promise you'll get it sorted. And also please engage. Let us know where you're watching from, make some comments, but also ask questions, and we will endeavor to answer as many as we can towards the end of tonight's event. Before I start, a massive thank you to our partners who are Obesity. I think without your commitment to independent education, a passion for research and innovation, these events simply would not take place. So a massive thank you from me, from Tobias and from the team. So without further ado, it gives me great pleasure to hand over to our speaker, Dr. Bertsch. Thank you so much. My pleasure.
Thanks so much.
Thank you so much.
Yeah, big legs, always lipedema syndrome? Of course not. But first of all, let me thank you, Jobst, for giving me the opportunity to speak about this exciting topic and to clarify this essential question. Now, but let us start with some patients. Patients with big legs, patients like this patient here with primary lymphedema, or patients with secondary lymphedema after cervix cancer, or this patient with obesity-related or obesity-induced lymphedema. All these patients have big legs, also these patients. Patient with a primary lymphedema, which is obesity aggravated, or patient with venous and cardiac edema, or this patient with Klippel-Trenaunay syndrome. I think you will agree all these are patients with big legs, but they don't suffer from lipedema. So let's talk about lipedema syndrome. And we had a very nice talk this morning with Gabriele Erbacher from Germany, from Ad Hendricks, with Robert Damstra, with Günter Kloos this morning about the syndrome. And I'm very happy that all of them agree that lipedema is a syndrome. And I would like to explain what is the difference between syndrome and disease. And a syndrome refers, as you probably know, to a group of symptoms, while a disease refers to an established and well-defined medical condition. And lipedema syndrome, ladies and gentlemen, is by far not a well-defined medical condition. A disease like breast cancer, like myocardial infarction, or like diabetes. We don't have any lab values, no histology findings, no ECG findings that tells us this patient is suffering from lipedema syndrome. What we have is our medical history, in which the patient tells us about her complaints, her symptoms. We have our eyes, our hands to examine the patient. So what we have in the end are symptoms that in their totality form a syndrome. So in this sense, lipedema is quite different from a well-established medical disease. It more belongs to the category of syndromes like hand-foot syndrome, chronic fatigue syndrome, or fibromyalgia syndrome. I think this clarification is essential. And this lack of clear diagnostic criteria also leads to misdiagnosis by health professionals. Professor Reisauer, the head of the lymphology department of the Charité of the University of Berlin, reported that 82% of the patients who are referred to her center with a diagnosed lipedema are misdiagnosed. 82% at the Foeldi-Clinic, which is the European Center of Lymphology. We have 76% misdiagnosed patients. So please note, the vast majority of patients seen by the two largest centers in Germany are misdiagnosed. And to address this problem of uncertainty, misinformation, misdiagnosis, renowned experts in this field came together in November 2021 to the third International Lymphoedema Forum in Copenhagen, and together we founded the ILA, the International Lymphoedema Association, the first society in this field only consisting of health professionals. And on the ILA website you will find seriously based scientific information about the lipedema syndrome, and you will also find the consensus document, which is now supported from renowned experts from 25 nations worldwide. On the website you will find this page here with quotes, for example, from the legend of lipology, Professor Hugo Partsch, who unfortunately passed away this January, and he quoted, let me quote from his foreword, "Lipedema neither includes edema nor is there any scientific evidence for lymphatic insufficiency." And on the website you also will find the definition of lipedema, which is mentioned in the consensus document. Here once again enlarged. According to the International Consensus document, there are two criteria which define lipedema. The first one is the disproportional increase of fat tissue in the legs, sometimes also in the arms, and the complaints in the fat tissue, of the legs. Plus is very important because that means the big legs alone is not lipedema. It's not lipedema. And let me emphasize, I ask every patient who is coming to me with a diagnosis of lipedema syndrome, I ask them, do these complaints really affect the quality of life? Are these complaints burden your daily life? If the patients say, no, it's just that I don't like my legs, I avoid public pools, that's not lipedema. Or if the patients say, only when I hit my legs, then it's painful, only then, that's not lipedema. We need the complaints to have an impact on the quality of life. That's very important. Now, how can I would like to emphasize or to explain these two criteria which define the lipedema syndrome. And let me start with the pain. When a lipedema patient is gaining weight, of course they gain fat tissue. And I never met a lipedema patient in the last 20 years since I treat these patients who didn't gain weight before the complaints start. Some 5 kilogram, some 50 kilogram. Then we see an increase in fat tissue, of course, and we know from great studies from the last years that there's immune cell infiltration in this fat tissue, hypoxia, which show that there is a low-grade inflammation, hypoxia in the fat tissue, which can lead to the pain symptomatic experienced by our lipedema patients. But this is only one side of the coin. According to our study, lipedema and pain, what is the role of the psyche? 80% of our patients of our lipedema patients display mental stress and disorders, 80%. And very important, this mental stress and disorder already existed before the lipedema complaints started. So purely in terms of pharmacologic, something that temporarily precedes the development of lipedema cannot be its consequence. In other words, usually it's not lipedema syndrome which leads to these mental issues of our patients. These mental issues already existed before the complaint started. Which leads us to the next coin, to the second coin. A huge majority of our patients suffer from chronic stress, anxiety disorder, post-traumatic disorder, eating disorder, depression, and this can increase the pain because of the increased pain perception. We have great data here from other medical fields, oncology, rheumatology, where we see quite similar processes. Now from this criterion, pain, to the next criterion, the disproportionate fat tissue. And that's just not that easy. I think everybody of you at home or here in the room will agree that this patient has disproportional fat tissue in the thighs. And when she has complaints there, then we would call this lipedema syndrome. But what about these patients? Although both women, I would say women, not patients, were referred to the Foeldi-Clinic, and with a diagnosis given by health professionals, lipedema syndrome. May I ask here the audience, who of you would say that both ladies on the right side have disproportional fat tissue? Hand signal, please. Who would say it's disproportional? The other way around, who would say it's not disproportional? So the huge majority say it's not disproportional. I agree with you, it's difficult. But when you ask the women, they say, I don't like my legs, I don't go to the public pools because of my legs. So you see, this is a problem. The patient view is quite different, quite often, from the health professional view. And what about these patients? These patients also were referred to the to the Foeldi-Clinic with the diagnosis lipedema, and let me emphasize, only with the diagnosis lipedema syndrome. Only. Now, maybe these 3 women have lipedema syndrome if they have complaints in the adipose tissue of the legs. But I think you will agree that disease, all of them suffer from an additional disease. And this additional disease is called obesity. And this additional disease is, at least from my point of view, in the foreground. And we should focus on this disease also. Let's go to the differential diagnosis. Now there are this lipohypertrophy, which means the big legs without complaints, lymphedema, healthy legs, and no, ladies and gentlemen, obesity is definitely not a differential diagnosis of lipedema syndrome. Definitely not. Obesity is in most cases neither a misdiagnosis nor differential diagnosis. Obesity is an additional diagnosis, and in most cases, it is the main diagnosis. You should know that around 85%, and we have studies all over the world who say the same, around 85% of our patients with lipedema syndrome are obese, have a BMI more than 30, and so it's wrong to ask the question, is it lipedema or obesity? The patients suffer usually from both problems, and we should focus on both problems. And you should also know that 50% of our patients suffer from are severely obese. That means they have a BMI more than 40. And again, it's lipedema plus obesity. And to focus on lipedema in patients like these and to ignore the disease which is in the foreground, the obesity, is the same as when your house is on fire and you put out the fire in the garage. So back to the real differential diagnosis. Let's start with lipohypertrophy. But this is a woman with, of course, what I think you will agree, disproportional fat tissue in the thighs. But she has no complaints at all. I asked her, she came to my OPD and she said, no, I have no pain, no complaints, no tenderness, only these big legs. So this is lipohypertrophy. I think it's lipedema therapy, like compression, would not help her. So there's lipohypertrophy, but the disease, the problem which is in the foreground is of course obesity. And we have to treat the obesity. And for those who have an interest, you can watch my obesity lecture tomorrow at the ILF. There I will explain how we treat the obesity. Lymphedema. Now to briefly boil it down to the essentials, I think everybody of you will know lymphedema. The consequence of a lymphatic drainage disorder or an overload of lymphatic fluid is lymphedema, and these patients have fluid. What you can see, the pitting edema here in the soft tissue, and we have a positive stemma sign, and then we have good hints, important hints that this is then lymphedema. When this patient is telling you that she has no complaints in the legs, in the soft tissue, but she has swelling in the lower legs, in the feet. It's difficult sometimes for her to getting into the shoes, and sometimes she has a feel of congestion, feeling in the lower legs. Then, and when you examine the patient, you have the pitting edema, you have the positive stemma sign. Then you can say that's lymphedema. This is one differential diagnosis. But quite often we see, or not often, but sometimes we see patients like this patient who have pain in the soft tissue of the thigh and the swelling of the calf and of the feet. This is the patient I see maybe 2 or 3 times per month. She has lipedema syndrome plus primary lymphedema. So we have to treat both, of course. This is a patient with lipedema syndrome plus secondary lymphedema after cervix cancer. Of course, we have to focus on both. And this is the patient I see several times every day. It's my daily business to treat patients like these who are obese, obesity stage 3, lymphedema and lipedema syndrome. And you see here a leg in front of the lymphedema. That's very important for me to emphasize this. This is an obesity lipedema-associated lymphedema. This is not a lipedema-associated or lipedema-induced lymphedema. We have no pathophysiology why lipedema should cause lymphedema, but we know very well why obesity is inducing lymphedema. Same like this is an obesity stage 3, patient with obesity stage 3, obesity-associated lymphedema plus lipedema syndrome. And we have to focus on all these 3 diseases. But please forget the term lipolymphedema. Lipolymphedema suggests that lipedema leads to lymphedema. Lipolymphedema suggests that lipedema is the cause of lymphedema, but we do not have any scientific evidence for this popular view. At the Foeldi-Clinic, which is the European Center in Germany at the Charité at the University of Berlin, we never used this term for many years. This is an obesity-associated lymphedema, and we should focus here, particularly in patients like these, on the obesity first. Now, this is, in my view, the most important differential diagnosis: healthy legs. What is disproportionate and not is often determined by the spirit of the time, by the Zeitgeist, the German word Zeitgeist. And it would be wrong to say that only women with this body or leg shape or this have normal legs, and the other 3, they have sick legs. And it would also be wrong to say that only the lady in the middle has normal legs and the other legs are sick or are ill. Now, unfortunately, this reality experienced on a daily basis looks quite different. Many women who do not conform to the current ideal of beauty feel stigmatized and suffer from a lack of self-acceptance. The following examples will explain this. Now, at the ISL conference in Buenos Aires 4 years ago, I visited in the morning at the art museum, and I saw, in the early morning, I saw pictures like these. This woman today, many would say she has big legs. At that time, she was a beauty, more than 100 years ago. And in the afternoon, I saw pictures from surgeons like this one, who prepare patients with lipedema, ? for liposuction. Beauty in the sleeping room, 130 years ago. Today we would say this is disproportional, and this is how today is diagnosed lipedema stage 2 and is prepared for liposuction. Now, the topic of self-acceptance, ladies and gentlemen, is a mirror of our society and an issue for many women, not just for women with lipedema syndrome. But in a time when thin legs are considered the ideal of beauty, in a time when women with non-thin legs feel stigmatized, women with lipedema particularly have an issue with self-acceptance. So you see, it's not always easy, but it's always worth it. To summarize the complaints of our patients, let me give you an idea with this picture. This bowl represents the diagnosis of lipedema syndrome. Lipedema as a diagnosis offers reasonable explanation for all these different problem areas of our patients. And of course, our patients suffer from pain in the soft tissue of the legs, sometimes the arms. But the pain perception, as I showed, is strongly connected with the mental stress, the depression, the stress level of our patients. And of course, they suffer also from their mental issues. Patients with lipedema syndrome suffer from weight gain. As I said, 85% are obese, 50% are morbidly obese. And many of them suffer from a poor fitness. I can't walk the stairs. And when they feel stigmatized because that obesity is stigmatized in our society. And of course, they suffer of a lack of self-acceptance because of the current ideal of beauty. One thing is clear, ladies and gentlemen. Edema or lymphatic insufficiency is definitely not the cause of the misery of our patients. Now, on the ILF website, you will find serious and scientifically based information. You also find the international consensus document. Now, maybe some of you have already asked yourself the question, why hearing my lecture, why me? I'm a vessel specialist. I'm a lymphedema therapist. Why do I have to take care of these patients? Let me respond to you. Who else? You are the expert for leg issues. As a lymphedema therapist, as a medical doctor for venous or lymphatic diseases. As a health professional, empathy and listening is among your strengths, and that's what your patients needs first and foremost. Compression therapy and movement therapy are the treatment tools you already use for your patients with lymphedema. And after this lecture, and after the lecture organized by the ILA tomorrow here at the ILF conference, and also on Thursday, you will have the knowledge to educate your patients. So again, my question, why me? Because you can. Thank you.
Thank you so much. I think that was an excellent presentation, but an important presentation. And thank you to all you guys for joining us. We've had hundreds of people around the world actually watch us live, so it's fantastic. I have some questions that have come through from you guys, so I'll start now. So question 1, can lipedema extend to the abdomen?
There's no scientific evidence for this issue. I know that a few colleagues in the United States stated this in their so-called international consensus, or in their standard of care. This is a publication from American colleagues. We don't have any scientific evidence for this. For me, it's if the belly is always also involved, then we should more focus on the obesity. And Günter Kloos and I from Kloos Training, we have tomorrow a lecture where we will refer to this misinformation. Okay. So lipedema of the abdomen, in my view, in our view, is a misdiagnosis, is a misinformation.
Okay, thank you. Question 2. Which diet would you recommend in obese patients?
Which diet?
Yes.
We had this conversation half an hour ago with Bea Kut from the Netherlands. The word diet is a very unfortunate term.
Yes.
We should call it healthy food or healthy eating. It's much better, because diet is usually connected with any commercial diets like keto or Weight Watchers, low carb, low fat. And I say to my patients, and the data for this, for my statement is very convincing, diets lead to a dead end. You should know that 95% of all dieters, 95% will regain their weight in 1 to 3 years. The data for that are very convincing. Yes. We have data from the last decades. So back to your question, no diets, yeah, but healthy food, healthy eating. I say to my patients, eat in the morning until you're full, have a lunch, have a dinner, eat like your grandmothers.
Yes.
Cooked, yeah, cooked, or grandfathers, sorry, probably there's some grandfathers who have to cook, but eat like them, yeah. Avoid processed food, yeah, and that's all, yeah. Nothing, no special diet.
Thank you. I've been taking those notes myself. So thank you. Is easy bruising common in lipedema?
It's also a topic of the lecture of Günter and mine today. So for the people who ask these questions, I would recommend the ILA session tomorrow and on Thursday, where all these questions will be responded in detail. So easy bruising you can read on every patient website. Yeah. And patients read that, and then they come to us, and when I ask them, what are your complaints, they say, oh, my legs are swelling and I have easy bruising. This is a sentence I hear 15 times per day. But we don't have data for easy bruising, but in the meantime we have data that there is no easy bruising in lipedema. No. There is no easy bruising in lipedema syndrome. We have data from the Foeldi-Clinic. We published in good papers, so there is no evidence for easy bruising.
Okay.
Maybe one sentence to that easy bruising. I think nobody would really suffer from easy bruising. Yeah, if you have easy bruising that comes, you have it 3 weeks, then it's changing the color from green to yellow, and then it's away. Yeah. Yep. So nobody is suffering from easy bruising. So easy bruising plays. I never ask a patient who is referred with lipedema syndrome whether she has easy bruising. doesn't play a role.
Fantastic, thank you. We have 2 more, and then we are finished.
Okay.
So question 4, do you see progression of the disease in your lipedema patients like we always see in lymphedema?
I love this question, great question. Lipedema is not progressive. It's not a progressive disease. We see patients now at the Foeldi-Clinic, we treat over 20, 30 years, who are completely stable because the weight is stable. When the weight remains stable, lipedema syndrome also remains stable. But what we in most cases see, that the weight is gaining, that obesity is progressive. And I think everybody of you patients will confirm that that many of your patients, when they are obese, maybe you see them 5 years later, 5 years ago they were BMI of 30, then it was 32, 34, 35. Obesity is a progressive problem, a progressive disease. And of course, when obesity is progressive, lipedema, as diabetes, as hypertension, as lymphedema, also can getting worse. But it's not because of lipedema is progressive, but the obesity.
Fantastic, thank you. So final question. Is liposuction an option for the treatment of lymphedema, so lipedema?
Definitely yes, if the patient selection is crucial, if the patient is not severely obese, let's say BMI, in my opinion, 32, but the consensus say less than 35. If the patient has a stable weight for the last years, if there are no severe psychological issues which play a role for the whole picture, then liposuction is a good option. But maybe you remember that I said the huge majority is obese, partly severely obese. Yeah. So for these patients, liposuction would be the wrong decision. If the patient has a BMI 35, 45, 60, or 55, then we treat our patients at the European Center of Lymphology, the Foeldi-Clinic, with bariatric surgery in a multimodal concept. They will have psychological assessment by Gabriele Erbacher, and when we say, okay, this is okay, then we refer the patient to the bariatric center, and these patients have a huge benefit, not only regarding the obesity, also regarding the lipedema. So back to your question, yes, liposuction can be an option. We don't have great independent data to that. We have only data by the surgeons, but I think we need more data. But if the patient has all the criteria which are mentioned in the international consensus document, I would say liposuction is an option.
Fantastic, thank you. And thank you for the event. I'm well aware of the time you've spent, not just today, but over the last few weeks and months putting this together, so it's hugely appreciated for me and the team. A massive thank you to the audience here today, to the digital team who always excel, and also to Jobst. As I said earlier, that commitment to independent education is crucial, not just to this event, but to healthcare professionals all around the world. So that concludes today's event. Thank you for joining us. We really appreciate your time. Stay safe, stay strong, and we'll see you soon at another event. Thank you so much. Have a good day.
Thank you.